My first talk relates to the treatment options for patients with germline BRCA mutations who receive neoadjuvant chemotherapy. As you know, the PARP inhibitor olaparib is now approved for the adjuvant therapy of high-risk hormone receptor positive or non-PCR and high-risk triple-negative breast cancer patients. Obviously, because of the survival benefit, it is now standard of care to use this agent after patients have completed their chemotherapies, if indicated, surgeries. Patients will receive this medication for 1 year. However, there are also other agents out there that were not tested in the pure germline BRCA mutated patient population, but have shown to be beneficial. For example, pembrolizumab, an immunotherapeutic agent, in the Keynote 522 study, when given in addition to chemotherapy in the neoadjuvant setting and after surgery for 6 months, did show a significant invasive disease-free survival benefit. The overall survival data is not mature yet, but this poses the question whether a patient with a germline BRCA mutation, after finishing neoadjuvant chemotherapy and surgery, and if high risk, should receive pembrolizumab for 6 more months, or olaparib, or the combination. Now, unfortunately, we do not have any data for this scenario, so it really depends on our extrapolation of data. What I would do, and have discussed in my talk, is to continue post-surgery with 6 more months of pembrolizumab, and then initiate 1 year of olaparib, because olaparib, as mentioned, has shown improvement in overall survival in this patient population. Another question is whether you should add capecitabine for high-risk triple-negative breast cancer patient after neoadjuvant therapy. And again, the same argument is relevant to this discussion as well. None of the post-neoadjuvant capecitabine studies reported outcome based on germline BRCA status. And now it will be a third drug that we might have to add. In my personal professional view, I think adding capecitabine after olaparib and pembrolizumab would be too much, and again, there is no data. The other scenario is for patients with hormonal receptor positive disease. As we all know, the monarchy trial showed a invasive disease-free survival benefit for patients with ER positive, ERN or PR positive disease when they received 2 years of the CDK4/6 inhibitor abemaciclib in addition to their endocrine therapy. As in the pembrolizumab trial, the analysis was not done by germline BRCA mutation status, so we really don't have any data. But this raises the question again. If we have a germline BRCA positive patient post-neoadjuvant and has hormone receptor positive disease, do we follow the Olympia-A trial and give 1 year of olaparib, or do we do 2 years of abemaciclib, or do we do the combination? Here's the caveat. Some early studies have shown that there might be concerns about cytotoxicity when both agents are combined. I also want to point out that so far we don't have any survival benefit for abemaciclib, but we have survival benefit for olaparib for germline BRCA positive patients. Therefore, my professional opinion would be in those patients to use 1 year of olaparib in addition to endocrine therapy, and maybe consider adding abema sequentially for 2 years. But again, this is in complete absence of any data.